So thank you all for coming. My name is Pat Tedlowski, and I'm on the faculty here. And I'm pleased to be able to organize the 29th Annual A. Daniel Rubenstein Lectureship in Gerontology. We have many faculty here and distinguished colleagues and preceptors and alumni, and it's just really great to see all of you and to see interest in gerontology because of a variety of factors. It's really becoming a topic near and dear to a lot of people's hearts, especially nurses. The William F. Cannell School of Nursing is pleased to sponsor this program with the generous support of the A. Daniel Rubenstein Lectureship in Gerontology and a gift to Boston College by the Friends and Associates of Dr. Rubenstein and also by Salter Healthcare in loving memory of Gershon Salter. Dr. Rubenstein died in 1996 at the age of 88. He served as Deputy Commissioner of the Massachusetts Department of Public Health and Director of State Hospitals during his career, which began in 1937 as an epidemiologist for the State Department of Health. He was President of New England Sinai Hospital, President of the American Association of Hospital Planning, Associate Professor at Harvard School of Public Health, and Visiting Professor of Epidemiology at the Massachusetts Institute of Technology. But most important, and what we really care about, is that he taught nursing students at Boston College. The lectureship was established as a tribute to Dr. Rubenstein's commitment to the care of the elderly, and we are pleased to have two of his family members here today, Dr. Joel Rubenstein and Susan Albright, so welcome. And welcome also to Beverly and to her colleagues from Salter Healthcare. We're pleased to have you here today. Salter Healthcare was founded by Gershon Salter in 1956 with the purchase of a 30-bed rest home in Woburn. Today, the Salters own a network of facilities which have a reputation for excellence in the healthcare community, and they serve thousands of patients and families. Gershon Salter was joined by his sons Robert and Richard, and since the death of Gershon in 1996, the tradition of excellence has carried on, so we greatly acknowledge your contribution. Today we're focusing our lecture on the improvement of end-of-life decisions in critical care units, the role of collaboration. ICU services account for $142 billion a year in healthcare costs, or 20% of all hospital costs in the United States. The cost of an ICU bed is 4 times the cost of a regular hospital bed. Staffing of the intensive care unit accounts for approximately 50% of the cost of ICU care. Those of you who work in ICU know the amount of things that have to be done. The nursing care required by the patient is intensive, and many times it's a 1-to-1 or 1-to-2 patient ratio. Each year, 4.4 million patients are admitted to ICUs. Unfortunately, ICU care is often a marginally profitable or money-losing operation for the healthcare system, especially for patients who stay longer than 6 days who are considered outliers. 67% of ICU costs are spent on outlier patients who only comprise 10% of ICU patients. As a result, the number of ICU beds has decreased steadily over the last 20 years, and we now have about 12.5 beds per unit because of cost constraints, administrative complications, and guess what else? A nursing shortage. These reductions come at a crucial time because Americans are aging. 47% of ICU patients are over the age of 65, and the cost of caring for an older ICU patient is 3 to 5 times more per day than the cost of resources utilized in the average acute care admission. Further, technology continues to advance. Demand for services is growing. The demand for nurses and physicians outpaces the supply, and there's good news and bad news about the baby boomers. The good news is we're living longer, and we're going to live 10 to 12 years longer on average than our parents. But the bad news is we're going to require more healthcare services, and we're going to put additional strains on the healthcare system. So how do we prepare ourselves, our students, our families, and our healthcare system for these changes? How do we evaluate the outcomes of healthcare and healthcare utilization with such scarce resources? How do we provide the needed valuable resources for these patients who will benefit from these scarce and precious resources? Luckily, Dr. Judith Baggs, professor of nursing from the University of Rochester, my alma mater, is here today to share her thoughts, opinions, and research outcomes with us. And I'd also like to acknowledge Ann Hurley, who helps us to recruit these national speakers from the Brigham so that we can share her expertise with you. Dr. Judith Baggs is Associate Dean for Academic Affairs at the University of Rochester, and her specialty includes critical care, nurse-physician collaboration, ICU decision-making, end-of-life decision-making, and she's published extensively and received numerous honors throughout her career. Dr. Baggs is currently principal investigator of the National Institute of Nursing Research study, ICU Culture and Problematic Treatment Limitation Cases. Dr. Baggs received her PhD from the University of Rochester. She has had training as a clinical scholar in ethics. She's completed the Harvard program in palliative care, and she's attended the Institute of Qualitative Research, School of Nursing, University of North Carolina. She has over 75 publications relating to end-of-life care, professional issues, education of healthcare providers. She is editor of the journal Research in Nursing and Health, and an international scholar. So we're very pleased to welcome Dr. Judith Baggs here today.
Well, one of the first things that people say to me when I deliver a lecture about gerontology and I'm talking about ICUs is, well, what do ICUs have to do with gerontology? Pat gave you some idea of that. The average age in any large-scale study of ICU patients, the average age is always between 60 and 65. So the majority of patients in ICUs are 60 and older. There's a lot of them. So it does indeed have a relationship to gerontology. This study was funded by the National Institute of Nursing Research, as have been both of my R01s. It's a great organization, and we need to support it, and it needs to get more federal funding. So if you want to do something in the area of policy, that's a good one. Thank you for inviting me to speak today. I always enjoy coming back to the Boston area. I'm a late comer to nursing. It was a second career for me. I was a high school English teacher. And I then went on, decided I wanted to go into nursing, and I already had a bachelor's degree, so why did I need another one? And I didn't get any good advice. So my first nursing degree is from Northern Essex Community College in Cable. And I've done everything since then, from that point on. My husband and I and our kids spent 6 years living in Groveland, which is a place unknown to many people in the Boston area. It's that only little town north of Boston that isn't on either 93 or 95. It's between Haverhill and Georgetown. And it's nice to be back. I'm going to talk about some current research on ICU decision-making at the end of life, decisions to withhold or to withdraw life-sustaining treatments or to maintain and increase that treatment, and the role of collaboration as those decisions are made. And my research has been primarily, or was primarily, on nurse-physician collaboration, and a lot of what I'll talk about today is that. But in the study, which unfortunately is no longer funded, although I've just been given credit for continuing to be PI on it, it was an ethnographic study of 4 adult ICUs. We spent 7 months collecting data in each of those 4 ICUs, and we broadened the idea of collaboration to include other healthcare providers and patients and families, as well as the nurses and physicians in the unit. A renewed desire to improve the care and the decision-making at the end of life that's provided to the dying has been demonstrated. We have initiatives from NIH, led by NINR, from private foundations, and from local communities and institutions. There definitely is much more interest in improving this, partially because we have some research showing that there are a lot of problems with both the care and the decision making. There's a growing recognition by healthcare providers and by the community that intensive technological care is not always the best kind of care to deliver to people who are dying. End-of-life decisions are decisions to limit or not to start life-sustaining treatments. Examples of that would include removal of mechanical ventilation, vasopressors, or choosing not to undertake cardiopulmonary resuscitation in the case of a cardiopulmonary arrest. In the largest study, which many of you have probably heard of, it was a multi-center, $28 million study. Money came out of the Robert Wood Johnson Foundation. The SUPPORT study, which is the study to understand prognosis and preferences for outcomes and risks of treatment. They found poor communication about prognosis, resuscitation, and patient preferences, lack of implementation of the patient's wishes, and refusals of treatment even after an intervention that was designed to improve the decision-making and communication. Family members reported that they believed that patients who died would have preferred, many of them would have preferred comfort care, but instead had life-sustaining treatments that perhaps made them less rather than more comfortable. They perceived dying patients as being troubled by symptoms, pain, but not just pain, dyspnea, fatigue, nausea. Researchers have found a lack of family access to the dying patient, and as care is more high-tech, there tends to be less family access. Lack of sensitivity to the family's plight, indications of overuse of technology, wide variations in how and for whom life-sustaining technology is used across units, and confusion about what comfort care means. And that's come up actually in the last couple of days as I've been talking to ICU nurses from the Boston community. We need further research about the decision making about limiting or not limiting life-sustaining treatment for ICU patients. The clinical and ethical context for decision making for providers and patients and families, they need to decide which interventions are appropriate, from full therapeutic endeavor, kind of everything that we can possibly think of, to comfort care, which we don't know what it is exactly. Both providers and patients are concerned about delivering or receiving more treatment than they consider to be beneficial. Care providers believe overtreatment is common, although Americans have expressed fear of dying without control, hooked up to machines. They also are afraid, in balance, that providers will decide to remove life-sustaining treatments before they have come to the decision that they want that to happen. And I would also say that the culture has changed so much. When I started ICU nursing, which was back in 1976, families were begging providers to remove life-sustaining treatment, and providers were saying things like, I can't, it's against the law, I could be sued, we have to do everything. And now, providers are ready, often very quickly, especially I think some of the younger providers, to remove life-sustaining treatment before families are ready for that to happen. And the judgment of those families in 1976 who wanted life-sustaining treatment was that they were dysfunctional. They didn't understand why we had to keep continuing the treatment. The judgment now of families who aren't ready to withdraw when some care providers are is that they're dysfunctional. So we put off onto the families a judgment when they don't meet our expectations for what the decisions should be. Limitation of treatment decisions are the quintessential ethical decisions. They involve combining information, clinical information, from both medical and nursing and sometimes respiratory therapy perspectives with values and beliefs of multiple participants, including those providers, and then making a decision that can lead to a patient's death. The ethical principles of autonomy and disclosure, truthfulness, and fidelity support inclusion of patients and families and those who can represent their case, who can support them as they're making their cases. There's been an increase in valuing over the last, say, 15 years of the principle of autonomy, leading to more support for including patients and families in decision-making. In the ICU, this is often families rather than patients, because patients are often unable to participate either because of their illness or because they're being sedated, because they're on ventilators. In part, this inability to involve patients occurs because we don't want to have those discussions until the patients are no longer able to participate in them. So moving those discussions to an earlier point in the process could be very helpful in terms of hearing the patient's voice. Ethically, the patient's wishes should be followed insofar as possible based on prior indications of preferences. And I will say the Schiavo case has driven many people to decide that they really need to start talking with their families and writing things down to make those wishes known. Patients have indicated a preference for shared decision-making with providers. Families have indicated that they want to be involved in decision-making. Good collaborative decision-making is strongly supported both conceptually and empirically among providers, patients, and families in ICU decision-making. An ethical model for good limitation of treatment decision-making requires involvement of providers and patient or family, building a consensus, sharing information, open communication, and supporting the patient's primacy in the decision-making. But in reality, we are often far from that ideal. There's a very nice review article on adult ICU end-of-life decision-making by Cook, who is a Canadian physician, and she reviewed the research on DNR orders and other treatment directives in ICUs and noted that ICU decisions are distinguished by a sense of urgency and uncertainty, a continually changing environment, and high costs. And she found, as Pat talked about in the beginning, she found disagreements among health professionals about decisions, weak correlations between what the provider and patient choices were, and the importance of the way the provider presented the question and the decision to be made to families, so that the words that the provider uses and the manner of that presentation can have a great influence on what decision the family ends up making. In terms of the epidemiology of limitation of treatment decisions for ICU patients, all studies indicate that we have many more times when patients who die in ICUs do not die after CPR, but after decisions have been made to withhold or withdraw treatments. And in most of those studies, patients very seldom are able to participate in that decision-making. Comparison of ICU patients who died in 1987, 1988 with patients who died just 5 years later, 1992, 1993, showed a great increase in the limitation of life support, little patient participation, and minimal use of advanced directives. And the number of patients in these studies that are described as able to participate starts as high as 35%, but in most studies it's more like 10% or 5% of patients that are able to participate. The process for limiting treatments in the ICU has been studied, and it's been described in a number of studies. Faber Langendoen, who is a physician, noted that it's often not until a patient is unable to interact, this is the being too late, and with others, that the wisdom of further aggressive therapy is questioned. They found that the decision-making is a process, doesn't happen in a single moment usually, occurs over several days and involves multiple decisions. So we may make one decision today. We may say we'll make the patient a DNR today, and tomorrow we'll talk about limiting drugs or limiting, begin to consider taking them off the ventilator. Or maybe it's not tomorrow, maybe it's next week before we come to that decision. There's a study by Jazuski, who is a nurse in Buffalo, who studied critical care nurses' experiences with establishing DNR orders. And the role of the nurse was ascertaining when the time was right to approach families to have this discussion with them, establishing a trusting relationship, providing information, supporting family decision-making, and that's often the nurse's role, and brokering interactions between the physician and the family, or among family members. Simmons is a Canadian nurse who interviewed ICU care providers, nurses and physicians, about their experiences with dying patients. And she found that both nurses and physicians were troubled by this issue of overtreatment and feeling that they were, in essence, being cruel to patients by putting them through difficult experiences. There's a wonderful study by Sharon Kaufman, who's at UCSF. She's a nurse anthropologist, and she did an ethnographic study of dying older patients in a community hospital ICU. She found that the technology of critical care led to few deaths that could be described as deaths with dignity, which is something we all talk about and hope for. She found more, not dignity, but ambivalence, especially on the part of family members, ambiguity about goals, uncertainty. Older adults who died in the ICU represented patients whom physicians and families and patients had decided to bring to the ICU because they thought the ICU treatment might be successful in saving the patient's life. So that it became difficult then to define them as dying, because you brought them to this situation with a hope that it would succeed. Discussion of treatment limitation became their way of allowing the dying process to begin. And there's a wonderful JAMA article by Tony Bach and Tim Quill that's called Hope for the Best, Prepare for the Worst. And if you begin discussions about the potential that this might not succeed, as well as all those discussions about how it might, it makes it not such a difficult transition when you want to begin to talk about the potential for removing some of the treatments and for recognition that the treatments just aren't getting you where you hoped they would. So again, having those discussions earlier and making the two things go together can be very helpful. So families need to know, patients need to know that we're going to try this, and it may work, but it may not work. And when we get to a point as we move along, we'll let you know how we're moving along that trajectory, but we all need to keep in mind that this may not work for the patient. The process then of allowing dying is the process when we begin to talk about removing treatments, and it's only allowed, and these are her words, when outcomes of specific treatments are repeatedly negative and the patient has an obviously downward course. And in our ethnographic study, one of the things that we observed in one of the units was that they seldom had these discussions early. They came very late in the patient's course, and that it might be such that at 2 o'clock in the morning a family was called to come in to participate in decision-making about withdrawing treatment, when it probably didn't make any difference if you withdrew the treatments or not. They were going to die within the next 12 hours anyway. So when those discussions begin can be very important. Family members in Kaufman's study were unprepared for decisions they were asked to make and didn't understand terminology like code status. And we observed some family meetings where the physicians were speaking in extremely technical language and asking families to make decisions that there was no way they could have understood. What it would, shall we start nitride? Shall we change the mode on the ventilator? I mean, it got so technical that you couldn't have expected families without healthcare backgrounds to have any idea exactly what it was they were being asked to decide about. And Kaufman found that provision of that technical information doesn't do anything for the ambivalence and the ambiguity of the families. It's clear that decision-making about end of life is complex, it's difficult for everyone involved, and the control over that decision-making rests primarily with providers. Even the control of saying, okay, you have to make this decision to the families is that the provider is controlling the fact that the family has to make a decision. Now I'm going to talk about different groups involved in this decision-making. The research on limitation of treatment decisions. I'll start with physicians because obviously they're key in this decision-making. There's evidence that physicians often make these decisions with very little input from anyone else. They feel personally responsible for making the decisions. They report continuing life-sustaining treatments when patients or families have asked to have them stopped. And they report removing or discontinuing or limiting treatments that they judge to be futile without having any conversations with patients or family members. Medical staff in one study identified families as the most difficult factor in end-of-life decision-making and care. Physician dominance of that decision-making occurs despite evidence that patients are more likely to have discussed their end-of-life wishes with their families, and when they're asked who they want to make those decisions for them when they're not capable, they generally prefer family members rather than somebody from the health team care, or joint decision-making. Physicians' decision-making has been shown to be guided by many factors other than patient or family wishes. Physician attending status, that is attending or consulting or primary care provider, specialty, age, gender, race, practice style, their own preferences for treatment at the end of life, and their religion are related to their limitation of treatment decisions for patients. Patient characteristics also influence physicians, so gender and race, and whether a cardiac arrest was iatrogenic or not also influence decisions that physicians make about limiting treatment. There are three kind of social and economic changes that may tend to lead to more physician dominance in the decision making. The first is a move toward closed ICUs so that only a small group of physicians are able to attend patients admitted to a unit, with often one intensivist in control of much of the decision making. A second is evidence of increased use of DNR decisions in ICUs. In recent studies of death in the hospital, only from 3 to 30% of patients actually in ICUs have CPR before they die. That means in 70 to 97%, treatment limitation has already been decided on. Now, often not for a very long period of time, as I described before, but it's been chosen. And then there's a literature about economic implications of when the DNR order is written. If it's written earlier in the stay, you're likely to save more money. A number of personal factors have been reported, and primarily these are in articles authored by physicians that relate to physicians' neglect of patient and family wishes. And these include familiarity with the technology, makes them difficult to understand the perspective of the family or the non-medical professional, a belief that they should have the power to do this decision making because they know more, briefness of interactions with families and patients, and this is certainly true in tertiary care centers and places where you're assigned your attending physician based on whatever organ system brings you into that hospital at that time. seldom somebody that you've known for a longer period of time. A wish to relieve families of guilt about the decision-making, a desire for certainty, and fear that the family is going to say they want everything done. And difficulty having end-of-life discussions with families. These are not easy discussions to have, and often physicians have not had any practice in how you go about doing that before they begin having it. In the study by Simmons, the Canadian nurse, ICU attending several of them told her that it was easier to continue active treatment until death so that they're not forced to make end-of-life decisions or to ask the family to make those decisions. It was easier to keep taking new treatments off the shelf until nothing worked anymore. The support investigators noted that the common physician practice of holding discussions about what kinds of treatments people want or don't until dying is imminent is not an appropriate decision, because in many diseases, especially cardiac and pulmonary diseases, patients are as likely to die in the next 5 minutes as they are to live for another 6 months on the day that they die. So you just don't know when they're at that point where they're dying until they have that arrhythmia or they have that respiratory arrest. In terms of literature on nurses, there are fewer studies of nurses' involvement in end-of-life decision-making. In the support study, the early article that came out said nurses were not very involved in treatment decision-making for patients. But in a later study where the intervention nurses were interviewed in more depth, they felt that they were very helpful in supporting patients and families. And I think nurses sometimes, if you ask them if they're involved in the decision-making, will say, no, they're not. They don't make the decisions. But their role is to support the families and the patient in what it is that they want. And that's very much involvement in the decision-making. ICU nurses have reported being frustrated about their limited role in this decision-making, and disagreement and confusion about the best way to care for patients at the end of life. Meg Campbell, who is a nurse practitioner in Detroit Receiving Hospital, which is an inner-city hospital, who started as the nurse practitioner on an interdisciplinary team led by physicians that goes into ICUs, identifies patients that are likely to die, offers to take over the care of those patients from attendings who often are perfectly happy to give over care of patients that they think are likely to die. And these are often patients who have no families, who have no primary care provider. She has now become the leader of that team. She's written extensively about her work as an advanced practice nurse and how they manage the care of people who are terminally ill. Her primary physician colleague in one of those articles identified the nurse practitioner as the central member on the team. There are some studies of nurses and physicians. We have evidence that ICU nurses and residents base their decision-making about patients on very similar factors, that if they're given scenarios that they respond very similarly to them about when you would think about withdrawing care treatment. I said something I try never to say, but which is totally ubiquitous in the ICU settings, and that's discussion about withdrawing care. It's withdrawing treatment. We have a book contract to publish the ethnography, and we wanted to call it Withdrawing Care, End-of-Life Decision-Making in the ICU, and of course all the reviewers said, no, that's terrible, but 99% of the time, that's how providers talk about withdrawal of life-sustaining treatments. So nurses and residents base their decision-making on similar factors. On the other hand, there are differences that have been demonstrated between nurses and physicians about what they consider to be the appropriate level of treatment. Other researchers have looked at problems between nurses and physicians and ethical decision-making, finding that nurses often identify ethical problems they are having with physicians, while physicians seldom indicate any awareness of the fact that there are ethical problems between what the nurses believe and what they believe. So there's a lot of evidence of this kind of ships that pass in the night, not identifying the same issues. And there's some evidence of a difference between nurses and physicians in the kind of problems that they identify. Nurses tend to identify more relational problems, problems with the family. Physicians tend to talk in terms of ethical decision-making using those principles that I talked about, autonomy and beneficence. So the involvement of healthcare providers in end-of-life decision-making in ICUs. There are differences by discipline and practice. Physicians have generally, in more recent years, been shown to be more willing than nurses to limit treatment. That, again, is a reversal of where we used to be in the 70s. ICU nurses' involvement in end-of-life decision-making is an area that is in need of further exploration. Dr. Millie Solomon, who's in Boston, and her colleagues surveyed acute care hospital nurses and physicians who worked with critically and terminally ill patients. Few thought that staff had found out what it was that the patient wanted. They didn't think that patients understood the information or that patients got the help that they needed in decision making. And they concluded that there was a need for more interdisciplinary discussion. Ash and a group of colleagues found that many ICU physicians made life-sustaining treatment decisions without knowledge or consent of patients and families. In studies of patients, again, Americans believe that patients should be the primary decision maker about care at the end of life, and their fears are dying on life support without control. There are data to support the capacity of patients to be included in decision making even as late as ICU admission, especially medical ICU admission, although patients often lose that capacity later. Researchers have found little involvement of any kind by critically ill patients in decision-making about limiting treatments. In one Canadian study, in 93% of the cases, the signal for having discussions about end-of-life decision-making was irreversible unconsciousness on the part of the patient. For others, treatment was limited only with a consensus that they were absolutely hopelessly ill, so we don't want to talk about it until it's late. There have been a number of studies of communication between providers and families or patients about limiting treatment. There is one study where they audio taped meetings of ICU physicians and families about decisions to limit. And they showed physicians narrowing options to those that they judged to be the best, a lack of provision of essential information by residents, domination of the interaction by the resident, and failure to consider patients' values and goals. And they have some amazing transcripts where the resident is talking to the family about a form that the resident has in front of them. So do you want your mother to be intubated and put on a ventilator? And the family member says something about how his father died only a year ago. And rather than saying, so how is that influencing you today? How are you feeling about that? How does that relate to the care of your mother? The resident kind of nods his head and says, so yeah, do you want her to be intubated and put on the ventilator? Recently, researchers found that ICU family members' satisfaction with family conferences about care of the dying. This is a lovely study out of Randy Curtis's group at Harborview Hospital in Seattle. When they had family meetings, the satisfaction of the family members with how those meetings went was directly related to how much time the family members were able to speak during those conferences. So that the more the family members were able to speak, the more satisfied they were with how those conferences went. And if you've attended very many family meetings, you may have noticed that often family members don't get a whole lot of chance to speak. The power of physician influence on families is indicated by a finding that 61% of the time families approached by physicians to limit treatment immediately agree. And when those studies are written up, they interpret that as the family being involved in the decision making. But nobody's gone out and asked those family members if they felt like they were involved in the decision-making, or if they simply acquiesced to what the physician had said. How physicians frame the decision has been identified as the most powerful factor in the treatment decision-making process. The major recommendations that families who have been through this process have made is for better communication from providers. In other studies, families of hospital patients who had died emphasized the value of their being involved in the decision-making. So how are families involved? There are 4 nurse-authored qualitative studies of families who had made or were in the process of making withdrawal of treatment decisions. In those studies, the quality of family-provider interactions was crucial to the decision-making process, to satisfaction with that process, and to the ability of families to live comfortably with the decisions that were made later, after the time had passed. There are a number of individual social and cultural factors that are important in decision-making. Patient age, race, and gender have been found to be related to the amount of treatment received, including ICU admission and ICU care. And we don't know whether that is because patients are saying, I don't want to be admitted to the ICU, or whether providers are deciding that, maybe not consciously, but this is an older patient, so they shouldn't be admitted to the ICU. And age by itself, if you control for comorbidity and diagnosis, age is not a predictor of whether patients survive or die in the ICU. It's not a predictor of how well they do after they're discharged from the ICU. But age certainly is important in provider decision-making, and we really need some work to find out how much of that is patient's choice and how much of that is provider choice. And the same is true for gender. In any studies of ICU patients, any big studies, almost invariably, the percent of patients in the unit is more than 50% male. Now remember that the average age of these patients is 60 to 65. There are more than 50% of the population at those ages that are female. And in hospitals, the percent of patients who are female is much higher than the percent that are male. So something's happening about the admission to ICU that relates to gender and relates to age, and it just isn't clear whether whose choice it is that's driving that decision making. ICU clinical interventions at the end of life have been studied. Generally, the interventions that have been proposed have not been based on research, and mostly on expert opinion. And the outcomes are often focused on how many advanced directives were completed. In the support study, nurse facilitators, the intervention part of it, after they randomized people, nurse facilitators were hired to improve patient to family to physician communication about end-of-life wishes. None of the outcome variables they looked at, and they looked at symptoms at the end of life, number of days in the ICU, number of days on a ventilator before death, none of those outcomes were changed by the intervention. There's a whole issue of JAGS about why that intervention didn't work. It's a number of different opinions. One of my favorite opinions is that there were no nurses involved in setting up that study. The intervention was developed by the physicians who put the study together, and then they hired, there was no educational requirement for the nurses that were hired into their jobs, and there was no requirement that they either have known the people in that ICU that they were working with, or whether they came from outside. So I think there are lots of reasons why it didn't work. Another reason that has been strongly proposed is that the interventions need to be at the system level, at the hospital level or the ICU level, not at the individual patient level. The effect of advanced directives in limiting treatment has been shown to be modest at best. Some patients have advanced directives that they have neither shared nor discussed with the person that they name in those advanced directives. I can remember a case where a young woman, HIV positive, was dying in the ICU. She had named her brother as her healthcare proxy to make decisions for her, but her family was totally dominated by her father. She had not spoken with her brother about the fact that she named him. Her father was furious, and the brother was afraid of the father, and it was a totally disastrous situation. So people need to know that if they're going to make advance directives, or if they're going to name a healthcare proxy or a durable power of attorney, they need to have conversations with that person about what it is that they want. There have been some interventions that have been described to improve end-of-life decision-making. One nurse-developed intervention was an interdisciplinary, case-based educational program for SICU residents. And actually, it showed some effect. Part of the problem with the interventions is what they tend to look at is length of stay and DNR orders, and it's not clear that those are the best things to be looking at as outcomes. There are two groups that have studied the effect of proactive ethics consultations. Another intervention involved patients, families, and care providers in meetings, and that's an intervention from Craig Lilly, who's at the Brigham, in meetings. So they identify patients who are at high risk of bad outcomes and have meetings with the family proactively. They begin to identify markers of either the patient's trajectory improving or worsening. They set time frames that they're going to be looking at these again, and they have continued meetings with families to continue those discussions. In those meetings, they discuss the patient's wishes, they agree on a care plan, and then those criteria for judging success or failure within time frames. All of these interventions that I've described were interdisciplinary, but the outcomes were, in most of them, are limited to patient length of stay and mortality. There are two other recent interdisciplinary interventions that involved new roles for advanced practice nurses. Only one of the interventions focused on dying patients, but both have the potential, I think, to improve care for the dying. Tom Ahrens, who's a critical care nurse, a CNS, formed a CNS MD partnership with as a team. The physician was the intensivist in the unit for patients at high risk of death, and it resulted in improved communication, shorter length of stay, and reduced use of resources. And they compared those patients not only with other patients in the unit that were cared for by other physicians, but also with patients who'd been cared for by the same physician in the past, and showed in every case an improvement. Vazirani added an NP to the medical team and improved communication and collaboration. There are a number of guidelines about how patients who are dying in the ICU should be treated, how limitation of treatment decisions should be made, what care the patient should be given. They are all based on expert opinion, not on research, and none of them have been tested in any studies going forward. So the implications for research are that we need both qualitative and quantitative research studies to assess end-of-life care and decision-making in ICUs. The experiences of patients and families and providers should be explored, and how those experiences change with interventions. Most studies have been of either providers or families. There are very few in which both were included in the same study. The influence of the culture of the ICU, which is what I was trying to study in my ethnographic work, variation in decisions made, reasons for that variation across units, the process of decision making, and variation in treatment all need further attention. Based on the research, 4 domains, I've identified 4 domains. There are a lot of people that have done domains, and I kind of pulled them down to 4. Each of these domains needs further study. The first is concerned with assessment of the best ways to relieve symptoms, such as pain or dyspnea or anxiety. And the research should, whenever possible, include primary data collection rather than data collection from families who act as proxies for what the patient is feeling. A second domain is assessment of ways to improve communication, to transmit information clearly and understandably to patients and families within the healthcare team. Timeliness and timing of communication needs to be studied, and assessment of appropriate ways to access and to honor advance directives, including both signed documents and verbal communications. A third domain is psychological support, again for the patient and for the family and for the members of the healthcare team, helping patients achieve a sense of control, helping patients accept and prepare for death. A fourth domain is assessing ways to improve interactions and relationships, again, within the family, within the care team, and between the two of them. Crossing relationships and decision-making is a study of what it means to share decision-making with patients and families and with various members of the healthcare team. If decision-making is collaborative or shared, where should the control lie? Are physicians willing to give up some of the control that they're exercising currently for willingness of other members of the team to share some of the responsibility for that decision-making? Improving the process probably will require framing it differently so that the knowledge of clinicians and the knowledge of the family and the patient is valued equally, because these are value decisions. It's not just a clinical decision. Most research on this topic has been retrospective. Few researchers have considered nurses' involvement in decision-making, and most have studied either providers or families. Prospective research that considers the involvement of families, patients, and all relevant providers is needed. It's important to assess why so few patients are involved in this decision-making. And if we don't wait until death, if we recognize that death is inevitable, perhaps we can involve more patients in the decision-making. There are other questions that haven't been studied. For example, no one has assessed whether the ICU is a good place for families, for care for patients who are dying. Would it be better to have a palliative care unit that those patients would go to, or will that be the possibility for expert palliative care be countered by the fact that you lose that continuity of care that is so important to families? They have a very difficult time figuring out who the heck all these people are, and once they get to know who some of those people are, it's very comforting to see those same people again and to interact with them. Intervention research is needed to assess how care and decision-making might be improved. The current intervention research has focused just on the outcomes of length of stay and mortality. That doesn't begin to help our understanding of how patients and families and providers experience the effects of the interventions. Development of interventions will require attention to types of ICUs where care is delivered. One ICU is not like another ICU, they're very different. Types of hospitals in which they're located and individual unit characteristics. The implications for practice are that those same domains that I talked about before are important for how we practice in ICUs. So relieving symptoms, improving communication, improving interactions and relationships, providing psychological support all need to be attended to as we care for patients in the ICU. We need sensitivity to the patient-family perspective. We know how things work in our hospitals and in our units, and patients and families don't. They're in a world that's strange to them. We call the family visitors, but in coming into the patient's room, we are the visitors in that situation. We need to recognize that there's that duality in how we think about each other. Proactive interventions that make changes systematic rather than reliance on multiple individual judgment offer some hope for the future. Finding ways to improve family access. This is one of the major wishes of families, to be able to spend more time with patients. Maintain continuity and deliver high quality care is a challenge. And And continuity has not been helped by 12-hour shifts. So that a nurse may work 3 days in a week. If the patient is there longer, they will have new nurses day and night. So we talk about nurses being at the bedside 24 hours, and we're very proud of that, but it's not the same nurse. It's a different nurse all the time, and that's difficult for patients to adapt to. The best chances, I think, for improved care at the end of life are in collaborative, interdisciplinary efforts to improve communication and interactions among all participants. We have empirical support for the positive effects of collaboration between ICU physicians and nurses. It's been supported in a number of studies. Staff interaction or coordination has been found to be critical in accounting for differences in mortality across units. There's a positive association of caregiver interactions, including communication, coordination, and other interactional variables that led to better ICU care, shorter risk-adjusted length of stay for patients. In an existing ICU which had 5 elements of excellence that the Critical Care Nursing Association had identified, a lower than predicted mortality was found. In 2 of my studies, I found that NICU nurses' reports of a high level of collaboration in the decision to transfer patients out of the ICU predicted lower mortality and less likelihood that those patients would be readmitted to the ICU. In addition to that empirical support for collaboration between nurses and physicians, there's strong conceptual and ethical support. Autonomy certainly supports patients or whoever their proxies are in decision making. The newer emphasis on relational or caring ethics also supports inclusion of patients and families in that decision making. Patients are more likely to have those discussions about end-of-life wishes with their families than they are with care providers. Both nurses and physicians have written of the importance of collaboration in making bioethical decisions. Collaboration allows input from different perspectives, increasing the amount of information available, which can only help us in making better decisions. With collaboration, there is sharing of information and perspectives, respect for patient and family autonomy, and disclosure. Some very concrete suggestions for improvement of the decision-making process have been gathered from family members whose loved ones have died in ICUs or acute care hospitals. These recommendations include encouragement of advanced planning, timely communication, clarification of families' roles in decision-making. Maybe we shouldn't be asking them to make decisions about the ventilator mode, but to tell us what the values of the patient are, to tell us what their values are. Facilitating family consensus, emotionally supporting family decisions, providing access to patients before and after death, and accommodating family grief. Behaviors that were not helpful included rigid adherence to standardized protocols, 15 minutes every 2 hours for visiting, for instance, lack of expressions of human caring on the part of providers, lack of personal attention to the family members, lack of information, and the appearance of detachment from the decision-making. Postponement of decisions and implementation. Once the decision has been made to withdraw treatment, postponing the implementation of that action until tomorrow or the next day because you have a different attending on and they don't feel comfortable doing it or whatever, can be very difficult for families. Once they've been able to bring themselves to the decision that it's acceptable to withdraw a ventilator, for instance, they don't want to wait 24 hours or 48. Delaying withdrawal, placing the full burden of decision-making on one person. And I don't know about your ICUs, but I know ICUs where what we want is to identify the family's spokesperson. And we don't want anybody else calling us except that family spokesperson, and that's the one we're going to talk to. And we end up putting the burden of decision-making on that single person. Families do not find that to be helpful. Delaying, and defining death as a failure. Jacob found that families want to work with caregivers in a collaborative interaction. They're willing to be participants in decision making. If they ask questions like, what would you do? They're willing to listen to you and then to consider what decisions they would make. When we first started thinking autonomy was important, the way we tended to implement that is, I'm going to give you the information and then you make the decision. They want our expert professional advice. And the family's long-term ability to deal with their grief was influenced by how that interaction worked. Collaboration enables providers and patients and families to have more information for decision making. It's supported ethically as a way to clarify and treat according to the patient wishes or to best approximate what the patient would have chosen. Interdisciplinary collaboration plays an important role in ICUs, that if nurses and physicians aren't getting along and are giving different messages to families, that's very difficult for families to hear. They want to know that we're all on the same page and that we know what we're doing. To meet needs of patients in an ethical, caring, and compassionate manner, professionals also must collaborate and work together with each other and with patients and families. Thank you very much. We have lots of time if people have either questions or comments. I'd love to hear what you're thinking about. Yeah.
I'd like to thank you for this excellent review of a very complicated matter. And I actually have a question that relates to your experience at Philly Care Fellowship at Mass General. And the question is, why do you believe that there is a difference, or regional, or do you believe there's a regional difference between palliative care units being successful in one part of the country versus another?
I actually, let's see, the program I took was at Harvard, and it's a 2-week program, 2 weeks, one April and 2 weeks the next November. Just to tell you a little about it, it is a combination of nurses and physicians. It's a very interdisciplinary process, and people really come together on a plane, not on a hierarchy, and hear both about how to practice as a palliative care practitioner, but also how to teach about palliative care. So they're looking for educators and they're looking for practitioners. I don't know that I can speak to why it works I don't know that it's regional. There may be as much difference from one hospital in the same city to another hospital as there is between a hospital in Boston and a hospital in Atlanta. There are a number of different models of how palliative care is being implemented. There are some hospitals that have a unit with palliative care beds. There are some that have scattered palliative care beds. I think more and more the model that I've been seeing is a consultation team, interdisciplinary, that has to be requested by the attending physician. Now what I heard this morning is the attending has to request it, but the nurses often initiate the request for the attending to request it. And clearly it's easier to make that request with some physicians than it is with others. And palliative care kind of grew out of the fact that hospice requires that you have a predicted lifespan of 6 months or less, that everybody in the family is willing to accept that you're willing to give up life-sustaining treatments. If you're on dialysis, you're definitely not going to live 6 months if you have to give up dialysis to go into hospice care. So palliative care says we can keep trying, we can keep hoping for the best, we can keep delivering some of that intensive technological care, but we can also begin preparing for the worst, and we can try to make that care as comfortable as it's humanly possible to make it. Yes?
Thank you for the terrific presentation. I get sort of been there.
Yeah.
And I get find myself nodding, including throughout your entire
Thank you.
presentation. So one comment and question. The one comment I would say is that so often one of the issues in relation to treatment at the end of life relates to issues of uncertainty.
Yes.
Of where we're going. And there's a whole lot of discussion about that. And I think notes here. And 3 times I wrote one time, what is prognosis, uncertainty, absence of data?
Right.
And that is just so important as this collaboration or whatever goes forward in being able to deal with these issues. It's a 70% chance, 8%, 90% chance, or 2%. And so much of that may be a variable in what goes on in these interactions between physicians, families, nurses, et cetera. So that's my comment. Would like your comments on that. And then maybe I can ask my question, or?
Let's do one at a time. I agree with you, and there's some lovely work by June Lunny, who works for the federal government on different trajectories. And the easiest trajectory to predict about is the oncology one, where somebody's well and then they have a decline that can be predicted with some certainty. There are also people who die suddenly. And then there are probably the majority of patients that we deal with who have a chronic illness, who have exacerbations and remissions, and so they get very sick. And this is a patient that can get us into trouble because we say, oh, he's not going to make it. Whoop, he does. Now, he doesn't go back up to where he was. He goes back up to a little lower than where he started out, and he does this again and again until finally one of those is the terminal one. And that prognosis is very difficult for those kinds of reasons. It's also a very difficult subject for physicians. Nick Christakis has written a wonderful book whose title I can't remember right at the moment, but it's all about how difficult it is for physicians to think about prognosis and to actually give it, especially to families and patients. That we're better at talking about that prognosis among the members of the healthcare team than we are about conveying that, because we always tend to be more on the optimistic side when we have those conversations with patients and families. So I think healthcare is full of uncertainty, and it's not easy to live with that. And sometimes I think nurses think they know when they don't necessarily. I need to tell you that nurses, like physicians, can be wrong in saying that somebody is dying. But I think we need to share that uncertainty, and that's also very difficult, I think, especially for physicians, to share a sense of uncertainty with lay people.
I guess the big problem is as soon as you begin to express that uncertainty, which is in fact the reality of the family's attitude toward what to do will be highly dependent on that issue. And that makes it sort of a tough situation.
I think it is, but I think we need to share with them that we're not certain. And that, I think, is how Craig Lilly's proactive family meetings work well, in that you have those conversations with people over time, and you begin to identify markers and treatments that you're going to try, and set a time frame at which you will come back together and discuss and see whether things have gotten better or have gotten worse.
My question was, I agree with you that the outcome is when to stay and the totality of disasters, being the older family, don't say anything about what's really going on. But I wondered if you had your brothers, maybe I'm sure you actually have, in terms of designing outcome measures, and wanted to study this, what 3 or 4 major outcomes would you be looking for to study this question?
I think this is a smooshy measure. I think family satisfaction and provider satisfaction with how the interaction went is extremely important. And families are going to have to live with how they feel about how those interactions went. So it's important for them to feel good, and for us to try to help them both do what the patient wanted and yet not fracture the family, so that they go out of the death of a patient never able to communicate with one another again. And that does happen sometimes, I think. there are extremely difficult family situations around this decision making. We have this, the aunt from California syndrome, who hasn't seen the patient in 20 years. It comes on the scene and everybody else is kind of ready at this point. They've watched the patient's decline and somebody outside wants to do everything, and then that can put back our decision making. Yes?
I think one of the most difficult scenarios is when you have a patient who goes to the hospital talking and
Oh.
looking like she's coming home in a few days, and her last words are the day before Thanksgiving, save me some of the turkey,
Right.
and she has died by the
Right. She arrests them during the night when the family is around.
It's
Yeah.
so shocking for the family. They keep saying to you, well, what happened to her? Why did this happen?
Yes.
And you have,
And sometimes you have no answer for them because you didn't expect
you
it.
know,
Yeah.
you
It's,
have all
it's,
of this with the one person can call and one son lives in California. Terrible.
yes.
Hey! I don't know your questions, but one of them that's just really pressing on my mind is in your ethnographic study, did you see much evidence of people with common goals and different ideas about how to get there, leading to attention? For example, you talked about one of the priorities of the domain is the need to relieve symptoms, and yet knowledge of how you relieve symptoms is unclear. And so you might have one person who does a treatment thinking that it will make their loved one more comfortable, whereas you have another person involved in the same situation, a provider, who thinks that that same treatment is causing suffering by prolonging life. And I'm just
Prolonging
wondering-
dying.
Yes, prolonging dying, yes. And I'm just wondering if you saw, when you were in those ICUs, attention in that direction.
I think we saw every kind of tension that you can imagine. Certainly the issue of the family member who wants suffering relieved and the family member who wants the patient to be awake and able to converse with them. Now those they aren't the same goal, but it can put providers in a very difficult situation if they think that not relieving the pain is indeed causing the patient to suffer. Although sometimes there are patients who would rather live with that suffering and be awake and be able to communicate with their families. So in those kinds of situations, I think if you can assess what it is that the patient would wish, it's extremely helpful.
Do you think that knowledge of how to provide comfort or what suffering is or how to prevent suffering is also needs to be improved?
I agree, absolutely, and for me, the people that are able to do that best are often the palliative care nurse practitioner and physician. We have a wonderful nurse practitioner physician team, and they come extremely clinically competent. They also come with great communication skills, and our NICU uses them all the time. In fact, we currently have an intervention trial going on where there's a palliative care nurse practitioner who's stationed. Our NICU and SICU are across the hall from each other. She's stationed in those two units, and she has a screening tool that she uses to assess all the patients in the ICU. And at certain levels of severity, she will begin to intervene, and as she decides that whether there's a need for the full palliative care team to come and see the patient, she can cause that to happen. And that proactivity, the proactive family meeting, I know Diane Meyer in New York City, who's a gerontologist, for a while anyway, was doing proactive palliative care consultations on everybody after they've been in the ICU for 72 hours or 48 hours or something. I think we need to begin to do those things ahead of time. We want both to have experts who know how to do good palliative care, but we also want that ability to be transferred to the people who live on those units, to the other care providers. So that the worry of some of the palliative care physicians I know is that other physicians will give over that care to them and not try to develop that expertise themselves. But I think they have wonderful expertise. Yes?
Thank you very much. As an outsider, I found it very informative and helpful. I have two questions. You mentioned in the intervention having a proactive ethics consultation.
Mhm.
Are you talking about, to amplify that, are you talking about immediately when there are cases coming up? Or are you talking about a longer range?
I think
presentation of that?
in at least one of those studies, it was 48 hours after patients had been in the unit. The ethics consultation committee would, or whether it was one person or a committee, would come and assess whether an ethics consultation would be helpful. They'd ask the family if they would like one, and then they would provide it.
But even longer range, would you say that would be something even in preparation for nurses and doctors and other people?
Well, I mean, I think there's a lot that we could do that would improve nursing education and medical education that could help us be better at this. Some of it is learning more about how to care for the dying, how to provide good comfort care, more about communication. I would love to see at some point in nursing and medical education a time when they would come together. And there are some schools that do this, that have classes that the medical students and often the nurse practitioner students take together so that they can begin to learn something about each other's professions. I know that in many nursing programs there's discussion about collaboration. The last time I asked a group of residents whether they learned anything about collaboration or indeed about nurses and what nurses do in their education, they all told me no, there was nothing. So we need to know more about each other. It will help us work better together.
Just one other,
Yeah.
would you include some clergy person in that notion of collaboration? For example, when you talk about immediate cases with the family, with the doctors, and with the nurses, as
Yeah.
an integral part of that collaborative process?
Yes, absolutely, and the respiratory therapist and the social worker and anybody who's been involved with the care of particular patients. And actually what I did as I moved from my studies of collaboration between nurses and physicians to this ethnographic work was to broaden the idea of collaboration to include other members of the healthcare team, and that varied. On some units, that was a pharmacist who always rounded with the team, who knew all the patients, who interacted with the patients. On other units, there was a nutritionist who always rounded with the team and who was very actively involved in patient care. On some units, it was a member of the clergy. I think as we care for patients, their spiritual needs, I think, are very important. But what I think we need to do, again, is assess with the family and with the patient what it is that we can do to help them, who it is that we can get for them to assist with their spiritual issues. And people have very different types of requests about that.
That was my question.
Okay. And in the family meeting material that the studies that Craig Lilly did, there are chaplains involved in those family meetings. It's lovely work. It's 2 articles that are 4 years apart. They're in the medical literature. I think they're in JAMA, but they're worth looking at. Yes.
For those patients that you talked about that tend to look like they're going to go down real fast and then maybe turn around, how would you respond to somebody that would say, well, aren't we imposing unnecessary stress on the family, because they're telling them they're going to have to make this big decision and they're going to have to.
I think we need to be very careful in our communications with family, and when there is that uncertainty, we need to recognize that. We need to recognize that our ability to predict is limited. And we certainly get ourselves into trouble if we hang too much freight with a patient who then survives the next time that they come in. So again, we need to hope for the best and prepare for the worst and have discussions that allow full expression of the fact that we're just not certain exactly